Okay, welcome back to the deep dive. Today we are embarking on a truly deep dive into a particularly complex and critical area of medicine. We're spending our time with Chapter 94 of the source material you've shared, which lays out the landscape of paraneoplastic neurologic syndromes and autoimmune encephalitis.
It's a fascinating area.
It really is. And our mission is clear. We're going to peel back the layers, understand the intricate mechanisms, and extract every vital piece of knowledge so you can truly grasp these conditions at the level of, well, an elite professional.
Right.
Think of this as your shortcut to mastering this challenging topic. We're going to understand how cancer, in some really surprising ways, can trigger immune attacks that basically hijack the nervous system.
Yeah, let's get into this stack of information and uncover those critical connections. This chapter presents a fascinating challenge because it really sits at the intersection of oncology, immunology, and neurology.
Three big fields all meeting here.
Exactly. And navigating it effectively, which is our goal for you today, means understanding the why and the how, not just, listing off syndromes. We're going to break down the core principles that govern these disorders.
So let's start right there at the foundation. What exactly are paraneoplastic neurologic disorders, or PNDs? The term itself tells us they're para, meaning alongside, and neoplastic, related to a tumor or cancer. But the source is very specific about how they relate, isn't it?
It is, and that specificity is absolutely key. The source defines PNDs as syndromes affecting the nervous system that are associated with cancer, but, and this is the important part, they are not caused by the cancer directly invading the nervous system.
So not metastasis.
Not metastasis. Nor are they caused by other common complications of cancer or its treatment, like, say, strokes from a hypercoagulable state, or infections in someone who's immunocompromised, or the direct toxic effects of chemo or radiation.
Okay, so it's not the cancer cells physically damaging the nervous system or, the harshness of treatment. It's something else entirely.
Precisely. The defining characteristic, as the source emphasizes, is that PNDs are mediated by indirect mechanisms triggered by the presence of the tumor. And overwhelmingly, these indirect mechanisms are immune responses.
Ah, okay.
The body's own immune system is reacting to the cancer in a way that, unfortunately, inadvertently harms the nervous system.
So the immune system gets involved because of the cancer, and that immune activity then targets neurons or nerve fibers.
That's the core concept, yes. The tumor acts as the initiator, the trigger, but the actual damage is done by the misguided immune system.
That sounds like it wouldn't be a common thing, is it? Are these PNDs common?
Fortunately, no. They're relatively rare overall. The source indicates they affect maybe 0.5% to 1% of all cancer patients.
Okay, pretty low.
Pretty low. However, this number isn't static. The rate is much higher in specific cancers.
Which cancer should we be particularly aware of in this context? Where does that number jump?
You see a significant increase in association with neuroblastoma, and especially small cell lung cancer, SCLC. In those cases, the incidence of PNDs rises to about 2% to 3%.
Still relatively low, but higher.
Right. But the truly striking association, as noted in the source, is with thymoma, a tumor of the thymus gland. In patients with thymoma, the rate of developing a PND can be as high as 30% to 50%.
Wow, 30 to 50%? That's incredible. That makes identifying that specific tumor paramount if you suspect a PND.
Absolutely. It really highlights the importance of thinking about thymoma in patients presenting with certain types of PND.
And here's where it gets really fascinating. The nervous system acting as an early warning system, right? The source highlights that in a significant proportion of patients.
Yes, this is a critical point. In about 60% of patients, the neurologic symptoms of the PND actually appear before the underlying cancer is diagnosed.
60%. So more often than not, the nerve problems come first.
Exactly. This is huge for clinical practice. A patient presents with unexplained neurologic problems, maybe memory issues, imbalance, odd sensations, and that symptom ends up leading to the discovery of a previously hidden tumor.
That's powerful. Your brain or nerves are literally telling you something is wrong elsewhere in your body before anything else does. And these syndromes, they tend to come on quickly, don't they?
They do. The source notes that the onset is usually rapid, often over days to weeks, and the neurologic deficits can become severe quite quickly. This rapid progression in unexplained neurologic disorder should definitely raise suspicion for something like a PND or an acute autoimmune process.
And there's a note of hope tied to finding the cancer early. You mentioned diagnosing the cancer.
Absolutely. The source really stresses that prompt identification and treatment of the underlying tumor is crucial because it can actually lead to improvement in the neurologic outcome.
Ah, okay.
If you remove the tumor, you're removing the primary trigger for that misguided immune response.
So when a physician encounters a patient with these types of puzzling, rapid onset neurologic symptoms, the core task laid out in the source is kind of twofold. First, you need a high index of suspicion, right, to even think about a paraneoplastic or autoimmune cause.
Absolutely critical.
And second, if that suspicion is raised, then you need to aggressively search for and treat the underlying tumor if one is found.
Exactly. That diagnostic hunt for the occult or hidden tumor is often a defining feature of managing these conditions.
Okay, let's dig into the how. The source material delves into the pathogenesis, the mechanisms by which these conditions develop. You mentioned these misguided immune responses. How does the immune system get confused in this way? What's going on?
The primary hypothesis, particularly for many of the well-characterized PNDs, is based on what the source describes as. Well, tumors can sometimes start expressing proteins that are normally found only in neurons.
So the cancer cells themselves are somehow synthesizing or displaying these neuronal proteins? That sounds odd.
It does, but yes, they are. The developing tumor cells, through various genetic or epigenetic changes, might aberrantly express proteins that are usually restricted to the nervous system. Small cell lung cancer is a classic example given in the source. It's known to do this, expressing a whole variety of neuronal proteins.
Okay, so SCLC is a big one here. And then the immune system sees these neuronal proteins on the tumor cells.
That's right. The immune system recognizes these neuronal proteins on the tumor cells as foreign or abnormal in that context, outside the nervous system. This triggers an anti-tumor immune response involving both antibodies and T cells aimed at eliminating the cancer cells expressing these proteins.
Which is what you want the immune system to do.
Yeah.
Attack the cancer, but then it overshoots.
Exactly. The immune system learns to target these specific neuronal proteins because they're present on the tumor. But and here's the problem, because those same proteins are also present on the patient's normal, healthy neurons, the immune response doesn't stop at the tumor. It launches a collateral attack on the nervous system. It's a case of immunological cross-reactivity. The immune system is targeting shared antigens, and the nervous system ends up paying the price.
A biological case of mistaken identity, like you said, but the consequences are really severe for the nervous system?
They can be.
Oh.
And it's not solely about tumors expressing neuronal antigens. As the source mentions, other mechanisms can also be involved, especially in associations like with thymoma or lymphoma. In those cases, the tumor might cause a more generalized dysregulation of the immune system, leading to autoimmunity targeting neural structures without necessarily expressing the target protein itself.
Okay. The source puts a particular emphasis on antibody-associated immune responses, though, especially for PNDs involving the central nervous system. It provides these incredibly detailed tables, 94-2 and 94-3, listing numerous specific antibodies.
Yes, those tables are absolute goldmines for understanding this topic. They list the known antibodies, the associated syndromes, and the linked cancers. And detecting these specific antineuronal antibodies in the patient's serum or cerebrospinal fluid, CSF, is often a critical diagnostic step.
How helpful are they?
Very. As the source highlights, finding these antibodies often predicts the presence of cancer, especially when found in the context of a compatible neurologic syndrome. They serve as very powerful biological markers, like flags saying, look for a tumor.
And this is where the source introduces a really fundamental distinction that seems to underpin much of the chapter. Classifying these antibody-mediated PNDs based on where the target protein is located on the neuron. Is it inside the cell, intracellular, or on the cell surface, or at the synapse?
This is perhaps the single most important concept for understanding the different types of antibody-mediated PNDs. Seriously, if you grasp this difference, you're halfway there. The location of the antigen intracellular versus cell surface dictates the primary immune mechanism of damage, and, crucially, predicts how well the condition will likely respond to treatment.
Okay, let's really delve into that distinction then. It sounds critical. First, tell us more about the disorders associated with antibodies targeting intracellular antigens. The protein target is inside the neuron.
Right, so think inside the cell body or nucleus. The source lists prominent examples in Table 94-2. These are the classic unconaural antibodies. We're talking anti-HU, also called NA1, anti-YO, PCA1, anti-RV, anti-CRMP5 or CV2, the anti-MAPO proteins, MAME1, Me2, anti-Kilch-like protein 11, anti-amphiphysin, recoverin, bipolar cell antibodies, and even anti-GED in some contexts.
Okay, a lot of named antibodies there, and these are linked to specific syndromes like paraneoplastic encephalomyelitis, sensory neuropathy, cerebellar degeneration, opsoclonus, brainstem encephalitis, and others detailed in that table.
Exactly. Now, the critical pathogenetic point for this group, which the source illustrates nicely in figure 94:1 ACE, is that because the target proteins are located inside the neuron, the circulating antibodies floating around in the blood, or CSF, cannot directly access them in a living intact cell. The cell membrane is in the way.
Ah, okay. So the antibodies themselves aren't directly causing the problem by binding to the target protein itself?
Correct. The antibodies serve primarily as markers, really good markers, often indicating the underlying paraneoplastic trigger and the specific syndrome, but they're generally not believed to be the primary mediators of the neuronal damage in this group.
So what is causing the damage then, if not the antibodies?
Instead, as the source details, the immune response involves a vigorous infiltration of specific immune cells into the nervous system tissue. We're talking about lymphocytes, particularly CD4 plus helper T cells, and, crucially, CD8 plus cytotoxic T cells.
The killer T cell.
Exactly. Figure 94:1, G, visually shows these T cells right up against degenerating neurons, strongly implying direct cellular attack. Along with this T cell infiltration, there's activation of local brain immune cells called microglia and eventual scarring, or gliosis. The source strongly suggests that these T cells, especially the cytotoxic CD8 plus T cells, are the main culprits directly killing the neurons.
And they might use molecules like perforin and granzyme to do that, like little molecular weapons.
Yes, precisely. Those are cytotoxic molecules that CD8 plus T cells can deploy to basically punch holes in the target cell membrane, perforin, and inject enzymes, granzymes, that trigger programmed cell death or apoptosis, figure 94:1H. So in this intracellular antigen group, the damage is fundamentally a T-cell-mediated cytotoxic process, not direct antibody interference.
And this is why, as the source emphasizes, these syndromes are generally so challenging to treat.
Absolutely. It follows directly from the mechanism. Because the pathology is driven by cytotoxic T-cells destroying neurons, therapies primarily aimed at removing sphetolytic antibodies, things like intravenous immunoglobulin IVIC or plasma exchange plasmapheresis, are generally ineffective or provide minimal, if any, benefit.
Because you're removing the marker, not the killer.
You got it. The resistance to these antibody-focused therapies is a direct consequence of the T-cell-mediated mechanism. The main therapeutic strategy here is really twofold. Find and treat the underlying tumor, hoping to remove the ongoing trigger for the immune response, and potentially considering immunotherapies aimed at modulating the T-cell response itself, although even these often have limited success once significant neuronal loss has occurred.
Yeah, the example of anti-MAPO encephalitis is telling here. The source notes only about a 30% response rate, even with both tumor treatment and immunotherapy.
It really underscores the difficulty in reversing or even halting T-cell-mediated neuronal damage once it's significantly underway. These conditions, unfortunately, often carry a poor prognosis for neurologic recovery.
Okay, that clearly lays out the intracellular group. Antibodies are important markers, T cells are the primary killers, and treatment response is generally poor. Now let's pivot to the other major group, the antibody-mediated disorders targeting cell surface or synaptic proteins.
All right, this group is fundamentally different and represents a major area of discovery in neurology and neuroimmunology over the last, say, 15, 20 years. The target proteins here are located on the outer membrane of the neuron, or within the synapse itself, the critical junction where neurons communicate.
So the targets are accessible from the outside.
Exactly. Table 94.3 lists a rapidly expanding number of these antibodies. We're talking about anti-MDR and methyl D-aspartate receptor, anti-AMPAR, AMPA receptor, anti-GABAR and anti-GABA receptors A and B, glycine receptor antibodies, anti-MLOR5, metabotropic glutamate receptor 5, anti-LGI1, leucine-rich glioma and activated 1, anti-Caspr2, contact and associated protein like 2, anti-DPPX, dipeptidyl peptidase like protein 6, and many others.
And the syndromes associated with these antibodies are diverse, often named right after the target receptor, like anti-NMDR encephalitis, but also includes things like specific forms of stiff person syndrome, peripheral nerve hyperexcitability, and even neuromuscular junction disorders like LEMS and myasthenia gravis are mediated by antibodies to surface proteins.
Correct. The key distinction in pathogenesis here, as shown in figure 94-1, BDF, is that because the target proteins are on the cell surface or synapse, circulating antibodies can directly reach and interact with them.
So in this case, the antibodies themselves are directly.
Yes, that's the current understanding for most of these. The antibodies binding to the surface receptors or synaptic proteins are directly interfering with their normal function. The source describes several potential mechanisms for this interference, shown in Figure 94, the 3, DF.
How do they interfere? What are they doing to the neurons?
Well, several things. They can directly block the receptor's function, maybe preventing neurotransmitters from binding or stopping ion channels from opening. The source suggests this might be a mechanism for GABAB antibodies.
Okay, like putting gum in the lock.
Sort of, yeah. Or they can bind to the receptors and trigger their removal from the cell surface. They cause the receptors to be pulled inside the neuron through processes like antibody cross-linking and internalization. This is a really well-established mechanism for NMDAR antibodies, shown in Figure 94, the 3E. The receptors just disappear from the synapse.
So the neuron can't receive signals properly.
Right. Or a third way is they can disrupt the normal interactions between the target protein and other important proteins nearby of the synapse, subtly altering synaptic transmission without necessarily blocking or removing the receptor entirely. LGI1 antibodies, for instance, are thought to affect voltage-gated potassium channels and AMPA receptors by disrupting their interactions with other proteins, as shown in Figure 94-3F. The source also notes differences between antibody subclasses like IgG1 being good at cross-linking and internalization, while IgG4 might be less likely to do that, but more likely to just alter protein interactions.
So the damage isn't necessarily immediate neuron death, like with the T cells, but more of a functional disruption, a dysfunction of communication and signaling.
Exactly. Initially, it's often more about synaptic dysfunction than outright neuronal death, although prolonged dysfunction or severe inflammation can eventually lead to neuron loss too.
What about inflammation in this group? Is it different?
There is inflammation, yes, but it tends to look different pathologically from the intracellular group. You might see an influx of plasma cells, the cells that actually produce the antibodies, into the nervous system tissue. You can also see deposits of the antibody itself, IgG, bound to neurons or synapses, as shown in Figure 94, the 1 IgJ. And you often see microglial proliferation. However, there is typically less evidence of that widespread, intense cytotoxic T-cell-mediated neuronal destruction that characterizes the intracellular target group, Figure 94 to 1 IAJ. The primary insult appears more antibody-driven and functional.
And this difference in mechanism, antibody-mediated dysfunction versus T-cell-mediated destruction makes a huge difference in treatment response.
Absolutely. This is the really good news side of the story for many patients. Because the pathology is more directly related to antibody-mediated interference with surface proteins and potentially less about immediate, irreversible neuronal death, these disorders are generally much more responsive to immunotherapy.
Okay, so what are the standard treatments that work for this group?
Treatments are aimed squarely at reducing the pathogenic antibody levels or suppressing the overall immune response that's producing them. This typically includes first-line therapies like high-dose glucocorticoids, steroids, IVIG, and plasma exchange.
The treatments that didn't work well for the intracellular group.
Exactly. Here, they often work quite well. And for cases that don't respond sufficiently to those first-line treatments or have more severe or relapsing disease, therapies targeting the B cells that eventually become antibody-producing plasma cells, like rituximab, or sometimes stronger immunosuppressants like cyclophosphamide, are used as second-line options.
And tumor treatment is still important if there's an association, right? Even if the antibodies are the main problem.
Yes, absolutely crucial. If a tumor is present, like an ovarian teratoma in NMDR encephalitis or SCLC in GABAR encephalitis, removing the tumor removes the likely source of the antigen that triggered the antibody production in the first place. Combining immunotherapy and tumor treatment, when a tumor is present, generally leads to the best outcomes.
And the recovery rates can be quite good.
For many in this group, yes. Particularly for anti-NMDR encephalitis, the source cites recovery rates as high as 85–90% of patients achieving a good or moderate functional outcome with prompt treatment, although, importantly, cognitive recovery can sometimes be slow and take months or even years.
And the pathogenicity of the fact that these antibodies actually cause the disease has often been directly demonstrated experimentally.
Yes. This is a key point that really solidifies the understanding of many of these cell surface antibody disorders. Researchers have shown in laboratory models, for instance, by transferring antibodies from affected patients into animals, or applying the antibodies directly onto neurons in a dish, that these antibodies can directly cause the specific synaptic or neuronal dysfunction observed in the human disease. figure 94-3, figure 94-1F. This provides very strong evidence that these antibodies are not just passive markers, but are truly pathogenic. They're the agents causing the disease.
That's powerful confirmation of the mechanism. So, to really hammer this home, the take-home message is, intracellular antibody targets generally mean T-cell mediated damage, poor response to antibody removal therapies, and often a guarded prognosis. Cell surface or synaptic antibody targets generally mean direct antibody-mediated dysfunction, good response to immunotherapy, and often a much better prognosis for recovery. This is the critical fork in the road for understanding these conditions.
Precisely. Recognizing which group a syndrome likely belongs to, based on the clinical picture, or eventually the specific antibody identified, provides immense insight into its probable pathobiology, prognosis, and the most effective therapeutic strategies. It's a fundamental organizing principle.
The source also briefly mentions that not all suspected immune-mediated PNDs or autoimmune encephalitis have a known antibody target yet.
That's right. Opsoclonus-myoclonus syndrome is given as a prime example. While it has strong paraneoplastic associations neuroblastoma in kids, SCLC or breast cancer in adults, most patients test negative for the currently known panel of anti-neuronal antibodies.
So something else is going on immunologically.
It suggests other, perhaps yet to be identified, immune mechanisms are at play, maybe antibodies to different targets, or perhaps a primarily T-cell mediated process that we don't have markers for yet. And the source also notes that some late-stage neuropathies seen in cancer patients also have unclear causes, potentially multifactorial.
Okay, so if you're a clinician encountering a patient with new neurologic symptoms that could potentially be paraneoplastic or autoimmune, how do you navigate the diagnostic process? The source provides a kind of roadmap, doesn't it?
It does, and the approach logically depends on which part of the nervous system seems primarily affected.
Okay, let's start with suspected involvement of the brain, spinal cord, or maybe the dorsal root ganglia, the central nervous system territory.
Right. For this area, the process begins with clinical suspicion based on the patient's specific symptoms and how they evolved. Then you layer on imaging findings, particularly MRI of the brain and or spinal cord, and analysis of the cerebrospinal fluid, CSF, obtained via lumbar puncture.
And what role does antibody testing play here? How helpful is it?
Antibody testing for that panel of specific antineuronal antibodies we discussed from tables 94-2 and 94-3 is a crucial step. Detecting one of these antibodies, especially one known to be highly predictive of cancer in the right clinical context, like HU, Yo, Re, May2, CRMP5, Amphiphysin, GABAM, AMPAR, is a very strong piece of evidence supporting a paraneoplastic or autoimmune etiology.
Is it foolproof?
No, definitely not. And this is a critical point the source emphasizes. These currently known antibodies are only found in about 60% to 70% of patients with PNDs affecting the CNS or dorsal root ganglia.
So a negative antibody test does not rule out a PND or autoimmune encephalitis. That seems really important.
Absolutely critical. You cannot rule it out based on negative antibody testing. That is a major potential diagnostic pitfall to avoid. Many patients, particularly those with syndromes driven by intracellular antibodies where T cells are the main issue, or those with antibody-negative syndromes like most opsoclonus-myoclonus, will test negative for the currently identifiable antibodies. The immune trigger might be primarily cellular, or the antibody target might simply be one we haven't discovered yet.
Okay. What about MRI? Is it always abnormal in these cases?
MRI is vital, but often its primary role is actually to exclude other potential causes. You absolutely must rule out direct cancer involvement, like brain metastases or leptomeningeal disease, cancer cells spreading in the fluid around the brain and spinal cord, as these can sometimes mimic PND symptoms.
So it rules out the direct effects of cancer.
Right. In many PNDs affecting the CNS, the MRI findings can be nonspecific, showing just some subtle inflammation, or it might even be entirely normal.
Are there any exceptions where the MRI can be suggestive of a specific PND or autoimmune encephalitis?
Yes, there are some patterns. For instance, paraneoplastic or autoimmune limbic encephalitis often, but not always, shows characteristic increased signal abnormalities on flare sequences, specifically in the medial temporal lobes, figure 94-2A. That's a classic finding.
They're not unique.
Correct. That pattern isn't unique to PNDs. It can also be seen in other conditions, like certain viral encephalitis, such as herpes simplex virus or HHV6, or even in non-paraneoplastic autoimmune limbic encephalitis. So it's suggestive, but not definitive. Anti-NMDR encephalitis, as we mentioned, often has a normal MRI in about 65% of cases, or might show only mild transient changes, figure 94-2B. So a normal MRI definitely doesn't rule it out.
Any others with specific patterns?
Yes. The source points out that anti-GABA encephalitis might show striking multifocal, cortical, and subcortical flare changes, figure 94-2C, which looks quite different. And anti-log-associated cortical encephalitis can sometimes present with extensive cortical lesions, figure 94-2D. So specific MRI patterns can provide valuable clues in certain syndromes, but they aren't always present, and interpretation requires considering the whole clinical picture.
Okay, what about the CSF, the spinal fluid? What does that typically show?
CSF analysis, usually obtained via lumbar puncture or spinal tap, typically shows signs of mild inflammation. This usually involves a slight increase in the white blood cell count, predominantly lymphocytes, what's called a mononuclear pleocytosis, often less than 200 cells per microliter. You also often see an elevated protein concentration and sometimes the presence of oligoclonal bands.
What are oligoclonal bands?
Oligoclonal bands are distinct bands of immunoglobulins, antibodies, seen on CSF electrophoresis that are not present in the serum. Their presence indicates that there is antibody production happening within the central nervous system itself, which is a hallmark of CNS inflammation or infection.
So CSF usually shows some inflammation, but maybe not dramatically high cell counts like in bacterial meningitis?
Exactly. Usually mild to moderate inflammation is typical.
Do other tests help much, like electrophysiology, EEG, nerve conduction studies, or biopsy?
Electrophysiology, like an EEG, to look at brainwave activity, or evoked potentials to test nerve pathways, is generally not specific enough to definitively diagnose a PND or autoimmune encephalitis, though it can help characterize seizures or localized dysfunction. Tissue biopsy, like a brain biopsy, is obviously invasive and carries risks depending on the location. While it can be crucial to rule out other conditions like primary brain tumors, infections, or metastasis, the pathological findings in PNDs themselves are often nonspecific. You might see inflammation, microglial activation, and neuronal loss, but it doesn't usually reveal the specific underlying paraneoplastic trigger, unless you happen to identify specific immune cell infiltrates or antibody deposits characteristic of certain syndromes, like those shown in figure 94-1 GJ.
Okay, so for CNS PNDs, it sounds like diagnosis is really putting together a puzzle. The clinical picture, the CSF showing inflammation, maybe a suggestive MRI pattern, or maybe not, and antibody testing, which is very helpful if positive, but importantly, cannot rule out the diagnosis if negative.
That's a very good summary. It's often a constellation of findings, combined with excluding other possibilities.
Now, what about if the symptoms suggest involvement of the peripheral nerve, neuromuscular junction, or muscle? How does the diagnostic approach differ when it's outside the brain and spinal cord?
Here, the diagnosis often relies more heavily on the clinical presentation and a detailed neurologic exam focusing on motor strength, sensation, reflexes, and coordination. Electrophysiologic tests become much more central, specifically EMG, electromyography, to study muscle electrical activity, and nerve conduction studies, NCS, to assess peripheral nerve function. And sometimes, pathology from a muscle or nerve biopsy can be very informative.
How do you approach the search for an underlying tumor in these peripheral syndromes? Is it different?
The intensity and focus of the tumor search are very much guided by the specific neurologic syndrome identified. The associations are key here. As the source details, Lambert-Eaton myasthenic syndrome, LEMS, a neuromuscular junction disorder, has an extremely strong association with small cell lung cancer, SCLC. Something like 50-60% of LEMS cases are paraneoplastic, mostly SCLC.
So have you diagnosed LEMS?
If you diagnose LEMS, a comprehensive search for SCLC is absolutely mandatory. This typically starts with chest and abdominal CT scans, or perhaps a whole-body PET scan. And because the tumor can be very small initially or even develop later, the source recommends repeated cancer screening for at least 3 years, even if the initial scans are negative.
Okay, that's a very strong link requiring persistent searching. What about syndromes with weaker cancer links?
The source contrasts LEMS with, say, polymyositis, another muscle disorder that's listed as a potential non-classic PND. Polymyositis has only a relatively weak association with underlying cancer compared to dermatomyositis or LEMS. Therefore, extensive repeated cancer screening is not generally warranted for polymyositis alone, unless there are other clinical indicators raising suspicion for malignancy. The intensity of the tumor search should be proportional to the known strength of the association between that specific PND and particular cancer types.
That makes sense. The source also mentions checking for monoclonal gammopathy in cases of peripheral neuropathy. Why is that important?
Yes, for a peripheral neuropathy of unclear cause, particularly in older patients or if it has unusual features, testing the serum and urine for a monoclonal gammopathy, an abnormal antibody produced by a single clone of plasma cells, often called an M protein or paraprotein, is important. Finding a monoclonal gammopathy can indicate an underlying plasma cell disorder like multiple myeloma, or a related condition like MGUS, monoclonal gammopathy of undetermined significance, Waldenstrom's macroglobulinemia, or lymphoma. These conditions can cause neuropathy through various mechanisms: direct nerve infiltration, antibody effects, amyloid deposition, etc.
Are specific anti-neuronal antibodies helpful in diagnosing peripheral PNDs, like the Hu or Yo antibodies?
Generally, less so than CNS PNDs. The currently known specific anti-neuronal antibodies are less frequently detected in peripheral nerve syndromes. The source highlights only CRMP5 and Hu antibodies as being particularly diagnostically helpful in the context of definite paraneoplastic neuropathies. Finding Hu antibodies, as we discussed, strongly suggests a concurrent paraneoplastic sensory neuronopathy, dorsal root ganglionitis, is also present or developing.
So, if antibody testing is negative, which sounds like it might be common in peripheral PNDs, how is the diagnosis of paraneoplastic actually made?
As with the CNS syndromes, if specific antibodies aren't detected or aren't definitive, the diagnosis of a paraneoplastic peripheral nerve or muscle disorder really hinges on two key things. First, definitively establishing the presence of an underlying cancer, and second, thoroughly excluding all other possible causes for the neurologic symptoms.
What other causes?
This includes ruling out other cancer-related issues like nutritional deficiencies, example B12 deficiency, metabolic derangements, direct side effects of cancer treatments like chemotherapy-induced peripheral neuropathy, infections, or completely unrelated common neurologic diseases that could just be coincidental.
How are these hidden tumors typically found if the initial suspicion is high but the first look is negative?
The source suggests that combining CT scanning with whole-body FDG PT scanning is often the most effective strategy for detecting occult, hidden tumors that might be driving the paraneoplastic process. PET scans can pick up metabolically active tumors that might be missed on CT alone.
But are there exceptions? Tumors PT might miss.
Yes, and this is important. You have to remember specific high-yield associations. For syndromes strongly linked to certain tumor types that might not be very metabolically active on PT, like germ cell tumors, dedicated imaging is crucial. For example, in suspected anti-NMDR encephalitis, you need specific pelvic imaging, ultrasound, MRI, or CT, to look for an ovarian teratoma. In suspected anti-MED2 syndrome, you need a testicular ultrasound to look for a germ cell tumor. These might be missed on a standard PT scan.
This really reinforces the idea that a high degree of clinical suspicion, knowing the specific syndrome cancer associations, and using a targeted diagnostic approach are all paramount. You can't just rely on one test.
Absolutely. It's about recognizing the clinical pattern, knowing the odds based on the specific syndrome, and then choosing the investigations. Antibodies, imaging, CSF, electrophysiology that are most likely to yield the answer based on those known associations detailed so well in the source material.
Okay, with that diagnostic framework firmly in mind, let's dedicate some time now to spotlighting the specific paraneoplastic and autoimmune neurologic syndromes detailed in the chapter. This is where we can really dive into the clinical presentations, the specific antibodies involved, the key tumor links for each, bringing that elite professional understanding to life. Let's maybe organize this by the major categories we've already discussed. How about we start with the paraneoplastic encephalomyelitis, PEM, focal encephalitis group, the ones typically associated with those intracellular antibodies.
Sounds good. This is a broad category. PEM, essentially reflecting widespread inflammatory involvement somewhere in the central nervous system, brain, brainstem, cerebellum, spinal cord. Even if the patient's initial symptoms seem focused on one area, say just memory problems suggesting limbic encephalitis, the underlying pathology revealed by autopsy or extensive investigation is often much more widespread. And remember, these are the syndromes generally driven by T-cell mediated damage triggered by those intracellular antigen antibodies. So unfortunately, they generally have a poor prognosis for significant neurologic recovery.
Right, tough group. And the subtypes within this PEM category, what specific syndromes fall under this umbrella?
The source lists several key patterns or subtypes. There's cortical encephalitis, which is sometimes manifest dramatically as continuous focal seizure activity that's hard to stop, a condition called epilepsia partialis continua. Then there's limbic encephalitis, which is quite common in this group. It's characterized by an acute or subacute onset of symptoms like confusion, marked behavioral or personality changes, significant short-term memory loss, and seizures. The MRI often, but not always, shows those characteristic flare signal increases in the medial temporal lobes, figure 94-2A.
Memory and behavior changes.
Exactly. Then you can have brainstem encephalitis, sometimes called rhombencephalitis. This leads to symptoms related to brainstem dysfunction, like problems with eye movements, nystagmus, gaze palsies, sometimes opsoclonus, various cranial nerve palsies affecting facial movement or swallowing, dysarthria, slurred speech, dysphagia, difficulty swallowing, and significant gait unsteadiness or ataxia.
Affecting basic functions.
Very much so. Paraneoplastic cerebellar degeneration is another major one, causing profound problems with balance and coordination, severe gait, and limb ataxia. We'll discuss that in more detail separately, too. You can also have primary involvement of the spinal cord, myelitis, or the dorsal root ganglia, ganglionitis, leading to various motor and sensory deficits, muscle rigidity, myoclonus, and sometimes autonomic dysfunction. And speaking of which, primary autonomic dysfunction itself can be a feature, sometimes severe and life-threatening, affecting blood pressure, heart rate, gut motility, bladder function, and so on.
So it can really affect almost any part of the CNS. What are the key antibody-tumor pairings we need to know in this challenging group?
The most classic and probably most frequent association is between HU antibodies, also called ANA1, and small cell lung cancer, SCLC. HU-associated syndromes are often widespread, involving encephalomyelitis, sensory neuronopathy, and autonomic failure, and are very strongly linked to underlying SCLC.
HU equals SCLC, basically.
High probability, yes. CRP5 antibodies, also called CV2, are also frequently seen with SCLC, but occasionally with thymoma or other tumors as well. Patients with CRP5 antibodies can have a very diverse range of symptoms, encephalomyelitis, but also often characteristic features like chorea, involuntary movements, uveitis, eye inflammation, or optic neuritis, inflammation of the optic nerve.
Okay.
Then there are the MADR proteins, particularly MAY2 antibodies. These are highly associated with testicular germ cell tumors, specifically seminoma in younger men. But anti-MAT antibodies, including MAY1 and MAY3, can also be seen with SCLC or other non-testicular tumors, especially in older patients or women. Anti-MAT2 syndrome often presents with prominent limbic encephalitis, significant hypothalamic dysfunction, which can cause things like excessive daytime sleepiness or hypersomnia, temperature dysregulation or endocrine problems, and brainstem dysfunction, sometimes with cerebellar features too.
Testicular cancer link is key for MAY2.
Very key. Kelch-like protein 11, KLHL11 antibodies are another marker strongly associated with seminoma and other testicular germ cell tumors. These are typically linked to brainstem encephalitis, causing symptoms like ataxia, hearing loss, or eye movement problems, ophthalmoparesis.
Another testicular cancer link.
Yes, and amphiphysin antibodies. These are primarily associated with paraneoplastic stiff person syndrome, which we'll get to, but the source notes they can also be found in some patients who present with broader syndromes like encephalomyelitis, cerebellar degeneration, or opsoclonus. The main tumor associations for amphiphysin antibodies are breast cancer and SCLC.
Breast and lung for amphiphysin. So it seems like knowing the antibody in this group can give you a really strong clue about where to look for the tumor. And just to reiterate, the key clinical point is that these syndromes, driven by intracellular antibodies and T cells, generally don't respond well to antibody-directed treatments like IVIG or plasma exchange.
Precisely. Despite our ability to detect these antibodies, the underlying T-cell-mediated neuronal destruction seems very difficult to halt or reverse once it's established. Treatment really focuses on finding and aggressively treating the underlying tumor, hoping to shut off the antigenic stimulus, and sometimes empirical immunotherapy targeting T cells is tried, but honestly, the prognosis for significant neurologic recovery in this group is often quite guarded.
Okay, a sobering picture for that group. Now let's shift gears and move to the more treatment-responsive group, the encephalitides associated with cell surface or synaptic antibodies. This group seems to offer more therapeutic optimism, right?
It absolutely does. These conditions are often treatable, sometimes fully reversible, especially with early diagnosis. They can occur with or without an underlying cancer, though a tumor search is always important initially. Interestingly, some can even be triggered by preceding viral infections, like herpes simplex virus. And importantly, they often affect younger individuals, including children and young adults, who might otherwise have an excellent long-term prognosis if the condition is recognized and treated promptly.
Let's start with probably the most well-known and perhaps most common one in this group, anti-NMDR encephalitis.
Yes, this is a really crucial syndrome to know about due to its relative frequency among the autoimmune encephalitides and, importantly, its high rate of good recovery with appropriate treatment. It commonly affects young women and children, but it really can occur across all age groups and in both sexes. The clinical presentation is often quite characteristic, typically evolving through distinct stages.
What are those stages? What does it look like?
It often starts with a nonspecific viral-like prodrome, maybe fever, headache, fatigue, just feeling unwell. But then It typically progresses, often rapidly over days or weeks, into a severe neuropsychiatric state.
Neuropsychiatric? Like what?
Key features include prominent psychiatric symptoms. This can be psychosis with hallucinations or delusions, severe paranoia, extreme agitation or catatonia. You also see severe sleep disturbances, often profound insomnia initially. Significant short-term memory deficits are common. Seizures are frequent. Patients often have a decreased level of consciousness, fluctuating from agitation to lethargy or even coma. And one of the most striking features is the presence of complex, often bizarre movement disorders.
What kind of movement disorders?
Things like orofacial dyskinesias, involuntary movements of the face, mouth, tongue. Also limb and trunk dystonia, abnormal posturing, or choreothetosis, writhing movements. Autonomic instability is also a major concern, with wild fluctuations in heart rate, blood pressure, and temperature. And some patients can develop central hypoventilation, requiring mechanical ventilation in an ICU setting. It can be very dramatic and scary presentation.
You mentioned psychiatric symptoms are prominent. I recall the source mentioning it can sometimes present purely as psychosis initially.
Yes, that's an important point. In about 5% of patients, the initial symptoms are purely psychiatric, which can easily lead to misdiagnosis as a primary psychiatric disorder, like schizophrenia or bipolar disorder, especially in adolescents or young adults. Because the symptoms are so complex and varied, it can be mistaken for many other conditions initially.
How is it diagnosed then?
Diagnosis relies on recognizing the characteristic clinical syndrome, finding CSF evidence of inflammation, usually mild pleocytosis, maybe oligoclonal bands, and critically detecting the anti-NMDR antibodies, typically in both CSF and serum. Importantly, the antibodies are often produced within the CNS, intrathecal synthesis, so CSF testing is usually more sensitive than serum testing.
What about the MRI?
As we touched on earlier, the MRI is often normal, maybe in up to 65% of cases, or it might show only mild, nonspecific, often transient flare signal changes, perhaps in the medial temporal lobes, cortex, or cerebellum, figure 94 to be. So a normal MRI absolutely does not rule out anti-NMDR encephalitis. Its main role is often to exclude other mimics.
And the crucial tumor association.
The tumor link is very strongly age and sex dependent. In young women aged 12 and older, there's a significant association, the source says, around 46% with an underlying ovarian teratoma. Figure 94-4A shows NMDR expression in a teratoma.
Almost half of young women have this tumor.
Yes. In younger girls under 12, this association is much rarer, less than 7%. It's also rare in young men. In older patients, say over 45, about 20% may have other types of tumors found, including breast cancer, other ovarian cancers, non-teratoma, or lung cancer. But the ovarian teratoma link in young women is the strongest association by far.
And the treatment response, you said it was good?
Generally excellent, especially with early intervention. Prompt initiation of immunotherapy, typically first line with steroids, IVIG, or plasma exchange, often followed by second-line agents like rituximab or cyclophosphamide if needed, combined with surgical removal of the teratoma, if present, leads to good or moderate functional outcomes in the vast majority, around 85-90% of patients.
That's very helpful.
It is. However, it's important to counsel patients and families that recovery can be slow, particularly cognitive recovery involving memory and executive function. It can take many months, sometimes even years, to fully recover, and relapses can occur, the source mentions, in about 12-24% of patients, sometimes requiring further treatment.
Okay. The source also notes an interesting phenomenon. An autoimmune encephalitis occurring after herpes simplex virus, HSV encephalitis.
Yes, this is an important clinical scenario. About a quarter of patients who survive an initial bout of HSV encephalitis develop a secondary autoimmune encephalitis syndrome, typically weeks later. This is often mediated by newly developed antibodies, including anti-NMDR antibodies, but sometimes other cell surface antibodies as well.
How does this post-HSV form present?
It seems to differ slightly by age. In children recovering from HSV, it often manifests with movement disorders like choreothetosis and behavioral issues. In adults, it's more typically characterized by cognitive impairment and psychiatric symptoms. The source does indicate that this post-infectious autoimmune encephalitis might be somewhat less responsive to immunotherapy compared to the idiopathic or teratoma-associated forms of anti-NMDR encephalitis.
Interesting. Okay, moving through the list of cell surface antibody syndromes from Table 94.3, let's look at anti-AMPAR encephalitis.
This typically affects middle-aged women, although men can get it too. It usually presents as an acute limbic encephalitis, so prominent memory impairment and confusion, or sometimes primarily with psychiatric symptoms. A key feature here is its very high association with underlying tumors. Around 70% of patients are found to have a tumor, frequently lung cancer, breast cancer, or thalamic cancer. Figure 94.4b actually shows AMPA receptor expression on lung cancer cells, illustrating the likely antigen source in those cases.
So high cancer risk with AMPAR. What about the MRI?
The MRI often shows those typical limbic encephalitis changes the medial temporal lobe flare signal increase, similar to figure 94-2a. Relapses can occur, but like NMDR, it is generally responsive to immunotherapy and tumor treatment.
How about anti-GABA encephalitis? What's the standout feature there?
The defining characteristic here, the thing that should really make you think of GABA A receptor antibodies, is the presence of severe, often refractory, difficult to treat, seizures and status epilepticus. These seizures can be very challenging to control and may require intensive care unit support, sometimes even medically induced coma to break the seizure activity. It affects both children and adults.
Wow, severe seizures. And the MRI.
The MRI is often quite striking and distinct, frequently showing multifocal cortical and subcortical T2-FLR signal abnormalities, figure 94-2c, which looks different from the typical medial temporal pattern of limbic encephalitis.
Is it usually paraneoplastic?
Most cases are non-paraneoplastic, but the source does mention an association specifically with thymoma in some Japanese patient cohorts. Response to immunotherapy is generally good if initiated early.
Okay. And its cousin, anti-GABA encephalitis.
This one also typically presents as limbic encephalitis, often with prominent seizures early on. The MRI is more likely to show the typical medial temporal lobe flare changes characteristic of limbic encephalitis. The key difference from GABA is its strong paraneoplastic association. The source states that over 50% of patients with anti-GABA encephalitis are found to have SCLC.
So, GABA strongly points towards SCLC.
Yes, definitely need a thorough search for SCLC in those patients. It generally responds well to immunotherapy and tumor treatment.
You mentioned glycine receptor antibodies earlier when we talked about stiff person syndromes. Where do they fit within these exaltides?
Right, glycine receptor, GLIR, antibodies target an important inhibitory receptor on the cell surface, particularly in the brainstem and spinal cord, as shown in figure 94-5. They are associated with syndromes involving muscle rigidity, spasms, and myoclonus, often falling within the spectrum of what's called PERM, progressive encephalomyelitis with rigidity and myoclonus, or sometimes presenting as variants of stiff person syndrome.
Is it paraneoplastic?
While often non-paraneoplastic, the source notes that about 20% of affected adults have either a concurrent tumor or a history of one, most commonly thymoma, B-cell lymphoma, breast cancer, or lung cancer. GLIR antibodies seem to be more commonly found in the PRM phenotype compared to classic axial stiff person syndrome. Again, responds to immunotherapy.
What about anti-mGLR5 encephalitis, also known as Ophelia syndrome?
This is typically described as a nonspecific encephalitis, often presenting with confusion, memory problems, or psychiatric symptoms that can resemble limbic encephalitis. The MRI is often normal. The really notable feature is its frequent association with Hodgkin's lymphoma. It was named Ophelia syndrome after the Shakespearean character who developed psychiatric symptoms, linking it to the lymphoma association.
And the outcome.
The key here is the link to Hodgkin's and its reported high responsiveness to both immunotherapy and effective treatment of the underlying lymphoma.
Are there specific antibodies linked to movement disorders affecting the basal ganglia, like Parkinsonism?
The source briefly mentions anti-dopamine 2 receptor, D2R antibodies, being associated with a rare form of basal ganglia encephalitis, primarily described in children. This can cause abnormal movements, Parkinsonism, oculogeric crises, eyes getting stuck looking upwards, sometimes with psychiatric features. However, the source emphasizes that this specific syndrome appears to be extremely rare and, importantly, not associated with cancer.
Okay, rare and not paraneoplastic. Let's return to antibodies with more common tumor links or distinctive features. What about anti-LGI1 encephalitis? This one seems quite common.
Yes, anti-LGI1 encephalitis is now recognized as one of the most common causes of autoimmune limbic encephalitis, particularly affecting men over the age of 50, although women and younger individuals can get it too. It typically presents as limbic encephalitis, so subacute onset of memory loss, confusion, personality changes, and seizures. It's also frequently associated with hyponatremia, low sodium levels in the blood, and sometimes sleep disorders.
But there's a very specific type of seizure associated with it, right?
Yeah.
Almost pathognomonic.
Yes, absolutely. A highly characteristic, almost diagnostic, preceding or accompanying symptom in about 40% of patients is something called faciobrachial dystonic seizures, FBDS.
Tell me more about those FBDS. They sound unique. What are they like?
They are very distinctive and easily missed if you don't know what to look for. They're very brief, lasting just seconds, but often very frequent, sometimes occurring hundreds of times a day. They involve sudden, involuntary dystonic abnormal posturing contractions, typically affecting one side of the body, primarily the arm and face, fasciobrachial, but sometimes the leg can be involved too. They can be unilateral or sometimes switch sides or become bilateral. Patients are usually aware during them. They can even occur during sleep, sometimes waking the patient. Recognizing FBDS is crucial because they strongly suggest LGI1 antibodies and often predate the more severe cognitive decline.
And cognitive decline can be severe.
Yes. The source also notes that about 15% of patients with LGI1 antibodies can present with a rapidly progressive cognitive decline that can closely mimic a neurodegenerative condition like Creutzfeldt-Jakob disease or another rapidly progressive dementia. So it's not always just seizures and memory loss.
Is LGI1 usually paraneoplastic?
No, tumor association is actually quite rare, reported in less than 5% of cases, typically a thymoma if found. Most cases are considered non-paraneoplastic. There's also a strong HLA association noted, suggesting a genetic predisposition in non-paraneoplastic cases.
And treatment response for LGI1, how do patients do?
The good news is that both the limbic encephalitis symptoms and the characteristic FBDS usually respond very well to immunotherapy, particularly steroids and IVIG. Seizures often stop quickly with treatment. However, relapses are quite common, occurring in about 2/3 of patients, often requiring longer-term immunosuppression or repeat treatments. Cognitive recovery can also be incomplete in some.
Okay, common, treatable, but relapses often. How about anti-Caspr2 antibodies? Who gets this and what does it look like?
These antibodies also tend to affect older individuals, predominantly men over 50, similar to LGI1. However, the clinical picture with Caspr2 antibodies is often much more complex and multisystemic compared to the relatively focused limbic encephalitis of LGI1.
More complex how?
Patients frequently present with a combination of symptoms. The source lists encephalopathy, confusion, memory problems, cerebellar features, ataxia, incoordination, peripheral nerve hyperexcitability, neuromyotonia, muscle twitching, stiffness, cramps, dysautonomia, problems with autonomic functions like sweating, blood pressure, gut motility, insomnia, neuropathic pain, and often significant weight loss.
Wow, that's a lot going on.
It really is. It's particularly associated with a syndrome called Morvin's syndrome, which is classically defined as the triad of encephalitis, severe autonomic dysfunction, and neuromyotonia. Caspr2 antibodies are found in many patients with Morvin's.
Is Caspr2 paraneoplastic?
It can be. Overall, about 20% of patients with Caspr2 antibodies are found to have an underlying tumor, most commonly a thymoma. However, this rate is reported to be higher, around 40%, specifically in those patients who meet criteria for the full Morvin's syndrome phenotype. Similar to LGI1, there's also an HLA association noted in non-paraneoplastic cases. Response to immunotherapy is generally considered good.
You mentioned peripheral nerve hyperexcitability or neuromyotonia as part of Caspr2 and Morvin's. We'll cover that more specifically later when we talk about peripheral nerve syndromes.
Yes, exactly. We'll touch on neuromyotonia again in the peripheral nerve section, as it can occur in isolation, often antibody negative, or as part of these broader CNS syndromes associated with Caspr2 antibodies.
Okay. What about anti-DPPX antibodies? What's characteristic there?
The syndrome associated with anti-DPPX antibodies often has a notable prodrome or concurrent presence of significant gastrointestinal symptoms. This is a key clue, particularly chronic, intractable diarrhea and substantial weight loss, suggesting an underlying gut issue might be involved in the pathogenesis or trigger.
Okay, look for GI problems. And neurologically?
Neurologically, patients often present with prominent central nervous system hyperexcitability. This can manifest as severe agitation, confusion, hallucinations, paranoia, tremor, myoclonus, muscle jerks, seizures, or an exaggerated startle response called hyperaclexia. Nystagmus is also common. Some patients can develop symptoms resembling pure M, progressive encephalomyelitis, with rigidity and myoclonus.
Is DPPX linked to cancer?
Most reported cases do not have an identified cancer. However, in the few cases where a tumor association has been found, it has typically been with B-cell neoplasms like lymphoma or myeloma. Immunotherapy is usually effective.
The source lists anti-Neurexin-3 alpha antibodies, but notes limited experience. Anything key there?
Yes, the source mentions these antibodies have been described, but based on the limited experience so far, they don't seem to be associated with particularly distinctive clinical features, nor do they appear to be cancer-associated based on current data. So less clinically defined at this point.
How about the really unique-sounding anti-Ixalan-5 disease? What makes it stand apart?
This one is truly distinct from most other autoimmune encephalitis. Firstly, it typically has a much more chronic or subacute onset and progression, often over years, rather than the rapid onset seen in many others like NMDRR or LGI1. Secondly, the defining clinical feature is a very characteristic and prominent sleep disorder.
Sleep disorder is the hallmark symptom. What kind?
Specifically, it's a complex parasomnia involving both REM and non-REM sleep, characterized by abnormal movements, complex behaviors, and vocalizations during sleep. Patients might act out dreams, shout, or have obstructive sleep apnea features. This sleep disturbance is often the earliest and most prominent symptom.
That's fascinating. What other symptoms develop?
While the sleep disorder is key, other symptoms often develop gradually over time. These can include bulbar symptoms leading to difficulties with speech, swallowing, or breathing, gait instability, movement disorders like Parkinsonism or chorea, eye movement problems like gaze palsies, and sometimes a cognitive decline. It typically affects patients in their early 60s on average.
Is anti-Iglon-5 disease paraneoplastic?
Crucially, no. It is not associated with cancer. However, it does have a very strong association with specific HLA types, HLA-DRB110.01 and HLA-DQB105.01, suggesting a significant genetic susceptibility.
And treatment response for Iglon-5, does immunotherapy work?
Unfortunately, the source notes that the response to conventional immunotherapy, steroids, IVIG, etc., is often poor or limited in anti-LN5 disease. This might be related to the underlying pathology. Pathologic studies have shown a specific pattern of tau protein accumulation, tauopathy, predominantly in the hypothalamus and brainstem tegmentum, areas critical for sleep regulation and brainstem functions. This underlying neurodegenerative component might explain the poor response to immunotherapy.
So unique sleep disorder, chronic course, no cancer link, poor treatment response, and underlying tauopathy. Very different.
Very different indeed.
Going back to the generally more treatable cell surface antibody group, are there any specifically associated with cerebellar syndromes? We mostly linked cerebellar problems to those intracellular antibodies like anti-Yo, which have a poor prognosis.
Yes, that's an important point. While classic paraneoplastic cerebellar degeneration associated with intracellular antibodies like Yo is notoriously poorly responsive to treatment, some cerebellar syndromes can be associated with cell surface antibodies, and these tend to be much more treatable.
Which ones?
Table 94.3 lists several examples. Antibodies to PQ-type voltage-gated calcium channels, VGCC, which cause LEMSS, can sometimes cause cerebellar ataxia as well. Antibodies known as TR, targeting DNIR, are associated with cerebellar symptoms, particularly in Hodgkin's lymphoma. Metabotropic glutamate receptor antibodies, specifically anti-mGlu-R1 antibodies, are strongly associated with cerebellar degeneration occurring in the context of Hodgkin's lymphoma and are noted as being highly responsive to both tumor treatment and immunotherapy. Similarly, anti-mGlu-R2 associated cerebellar symptoms also appear highly responsive. Others mentioned include antibodies to SES6L2, GluK2, which can cause cerebellitis, potentially with swelling. And even NMDR antibodies can sometimes cause cerebellar signs as part of the broader encephalitis.
So, even if the main problem looks like cerebellar dysfunction, identifying the specific antibody, particularly if it's one targeting a cell surface protein, can tell you a lot about the likely outcome and the potential benefit of treatment.
Absolutely. It reinforces the principle. The location of the target, intracellular versus cell surface, and the specific antibody involved are key predictors of prognosis and treatment responsiveness for antibody-mediated neurologic disorders.
Don't assume all paraneoplastic cerebellar syndromes have a poor outlook.
Okay, that's a critical nuance. Now let's specifically address paraneoplastic cerebellar degeneration, PCD, in its classic form, the one most often associated with those intracellular antibodies like Yo.
Right, this is indeed a classic PND presentation. Patients often experience a prodrome, maybe some nonspecific dizziness, nausea, or visual disturbances like blurred or double vision. This is then typically followed by a relatively rapid onset, often over days to weeks, of severe cerebellar symptoms.
What are the hallmark symptoms? The core features are profound dysarthria, slurred, poorly articulated speech, severe gait ataxia, leading to a wide-based, unsteady walk and frequent falls, limb ataxia, incoordination of arms and legs, and often dysphagia, difficulty swallowing. On examination, you frequently see nystagmus, involuntary rhythmic eye movements, and sometimes other eye movement abnormalities like opsoclonus can occur.
What about imaging and pathology? What's happening in the cerebellum?
Early on, the MRI of the cerebellum is usually normal. However, as the condition progresses over weeks to months, you typically start to see cerebellar atrophy, particularly affecting the cerebellar cortex, reflecting the loss of cerebellar tissue. The hallmark pathological finding, if examined, is a significant and often selective degeneration and loss of Purkinje cells, which are the primary output neurons of the cerebellar cortex. Other cerebellar neurons and even certain spinal cord tracts can also be affected in some cases.
And the classic antibody and tumor links for this form of PCD.
The tumors most often associated with classic rapidly progressive PCD are SCLC, breast cancer, ovarian cancer, and other gynecologic cancers, and Hodgkin's lymphoma. The most famous antibody linked to this is anti-Yo, also called PCA1. Anti-Yo antibodies are very strongly associated with underlying breast cancer or gynecologic cancers, like ovarian or uterine cancer, and often present as a relatively pure cerebellar syndrome in women. However, as we noted earlier, virtually any of the intracellular antibodies listed in Table 94.2, like HuRi, CRMP5, Ma, can potentially be associated with some degree of cerebellar dysfunction as part of a broader encephalomyelitis picture.
And the treatment response for this classic, often anti-Yo positive form.
Unfortunately, and consistent with the general principle we've established for intracellular antibody syndromes, most patients who develop paraneoplastic cerebellar degeneration associated with intracellular antibodies like anti-Yo experience little or no significant neurologic improvement with treatment. This holds true even if the underlying tumor is found and treated effectively, and even with various forms of immunotherapy. While very rare isolated case reports sometimes describe stabilization or minor benefit, the general rule is that reversing this profound, likely T-cell mediated Purkinje cell destruction is extremely difficult. The prognosis for functional recovery is typically poor.
Okay, a tough one. Let's look at another syndrome with prominent eye movements and jerks. Paraneoplastic opsoclonus-myoclonus syndrome, OMS.
Yes, OMS is a clinically unmistakable syndrome, often quite traumatic. It's defined by the characteristic triad of opsoclonus, myoclonus, and ataxia.
Can you describe opsoclonus again?
Opsoclonus refers to rapid, involuntary, multidirectional, horizontal, vertical, torsional, chaotic, conjugate eye movements, sometimes described as dancing eyes. It's different from nystagmus, which is typically rhythmic. Myoclonus refers to sudden, brief, shock-like muscle jerks that can affect the limbs, trunk, or face. And ataxia, again, is incoordination and unsteadiness.
Does OMS always mean cancer?
No. Importantly, it can occur without cancer. This is called idiopathic OMS, which can sometimes follow infections, but it also has well-established paraneoplastic associations.
What are the key paraneoplastic associations for OMS?
In adults, OMS is most commonly linked to underlying lung cancer, especially SCLC and breast cancer. In children, there's a very strong link accounting for about half of all childhood OMS cases to an underlying neuroblastoma, a tumor arising from primitive nerve cells. In adolescents and young women, OMS can also occasionally be associated with an ovarian teratoma.
Is the pathology understood? What causes the dancing eyes and jerks?
The exact mechanism and anatomical basis are still not fully understood. Evidence points towards dysfunction within cerebellar circuits, potentially involving disinhibition of the fastigial nucleus, one of the deep cerebellar nuclei, which plays a role in controlling eye movements and posture. But the precise pathophysiology remains debated.
Are there specific antibodies usually found in OMS?
Interestingly, no. Most patients with OMS, whether it's paraneoplastic or idiopathic, test negative for the currently identified panel of anti-neuronal antibodies. This is a key point. It's often an antibody-negative syndrome in terms of the classic PND markers.
Any exception?
Yes, anti-Ray antibodies, also called NA2, can be associated with OMS in some adult cases, particularly those linked to breast, ovarian, or lung cancer. The source notes that the prognosis in anti-Ray-associated OMS might be worse if the underlying tumor isn't effectively controlled, potentially leading to progressive encephalopathy and even death.
How is OMS treated and what's the outcome like?
Treatment is definitely challenging. In children with neuroblastoma-associated OMS, the neurologic symptoms often do improve, sometimes significantly, with treatment of the tumor, surgery, chemo, combined with immunotherapy. Therapies like glucocorticoids, ACTH, IVIG, plasma exchange, rituximab, or cyclophosphamide are often used, sometimes in combination or sequentially. However, even with improvement in the motor symptoms, opsoclonus-myoclonus ataxia, residual long-term problems are unfortunately common in these children, including cognitive deficits, behavioral issues like irritability, anxiety, OCD, and sleep disturbances.
What about adults?
In adults with paraneoplastic OMS, the prognosis for neurologic recovery is less predictable. Immunotherapy alongside tumor treatment can sometimes help symptomatically, but significant or complete recovery is not guaranteed, especially in cases associated with anti-Re antibodies if the tumor proves difficult to treat.
Okay. Let's move down the nervous system to paraneoplastic syndromes of the spinal cord. Are these common?
The source actually notes that classic descriptions of specific paraneoplastic spinal cord syndromes, like subacute motor neuronopathy, which resemble ALS but stabilized, or acute necrotizing myelopathy, rapid destruction of the cord, seem to be reported less frequently in recent medical literature. The reasons aren't entirely clear, perhaps changes in cancer types or treatments, or maybe better recognition of alternative causes for spinal cord problems in cancer patients.
So, less common now, maybe. But some patients with cancer do get motor neuron problems, right?
Yes, the source acknowledges that some patients with cancer, particularly lymphoma, or those with monoclonal gammopathies, do develop progressive motor neuron issues that can resemble amyotrophic lateral sclerosis, ALS. However, it's often unclear whether this is truly a paraneoplastic phenomenon driven by the cancer's immune effects, or simply a coincidental occurrence of ALS in a patient who also happens to have cancer. Establishing a definite paraneoplastic link can be difficult.
What about actual inflammation of the spinal cord paraneoplastic myelitis?
Paraneoplastic myelitis is recognized. This involves inflammation within the spinal cord itself, leading to symptoms like progressive weakness and sensory loss in the limbs, often asymmetric, sphincter dysfunction, bladder bowel problems, sometimes segmentally localized myoclonus, jerking in specific body regions, or even neurogenic pruritus, severe itching without a rash. Myelitis can sometimes be the initial or predominant manifestation of a more widespread paraneoplastic encephalomyelitis.
What does the MRI show in myelitis?
The MRI of the spinal cord is key here. It typically shows characteristic abnormalities, specifically longitudinally extensive lesions, meaning they span multiple vertebral segments, with increased T2 signal within the cord, often involving both the white matter tracts and the central gray matter.
Are there specific antibodies or tumors linked to paraneoplastic myelitis?
It's associated with underlying breast cancer and lung cancer, among others. It can be seen in patients with CRMP5 antibodies or amphiphysin antibodies. Unfortunately, consistent with these often being intracellular targets, the prognosis for paraneoplastic myelitis is generally poor, with limited response to treatment.
The source also mentions neuromyelitis optica, NMO, briefly.
Yes, it mentions that NMO, a distinct autoimmune disorder typically caused by antibodies against the aquaporin 4 water channel and primarily affecting the optic nerves and spinal cord, can really occur as a paraneoplastic syndrome. However, it directs readers to another chapter for a full discussion of NMO itself, as it's usually not paraneoplastic.
Okay, let's move on to paraneoplastic stiff person syndrome, SPS. We touched on antibodies like amphiphysin and GAD earlier. Tell us more about the syndrome itself.
Stiff person syndrome is a fascinating disorder characterized by progressive muscle rigidity or stiffness, particularly affecting the axial muscles, trunk, back, abdomen, and the proximal leg muscles, leading to a characteristic stiff or tin soldier-like gait. It's also marked by superimposed painful muscle spasms, which are often triggered by sudden movements, unexpected noises, or emotional stress.
Does the stiffness persist all the time?
A key diagnostic feature is that the muscle rigidity and spasms typically resolve during sleep and under general anesthesia, indicating a problem with central nervous system inhibition, rather than a primary muscle issue. The syndrome exists on a spectrum, from classic axial involvement to variants like stiff limb syndrome, where symptoms are predominantly in one limb.
And the electrophysiologic finding, what does EMG show?
EMG is very helpful. It characteristically shows continuous involuntary firing of motor units in affected muscles, even when the patient is trying to relax. This reflects a failure of the normal inhibitory control over spinal cord motor neurons.
Which antibodies are involved here, and which point towards cancer?
The antibodies associated with SPS target proteins involved in inhibitory neurotransmission, particularly the GABAergic system. The two main ones are GA, glutamic acid decarboxylase, the enzyme that synthesizes GABA, and amphiphysin, a protein involved in synaptic vesicle endocytosis and inhibitory synapses. Figure 94-5 illustrates their locations.
Which one suggests paraneoplastic?
Amphiphysin antibodies are a very strong marker for a paraneoplastic etiology. If a patient with stiff person features has amphiphysin antibodies, you should have a high suspicion for an underlying cancer, most commonly SCLC or breast cancer.
And GAD antibody?
GAD antibodies, specifically GAD65, are actually much more common in the non-paraneoplastic form of stiff person syndrome, which is considered a primary autoimmune disorder, often associated with other autoimmune conditions like type 1 diabetes or thyroiditis. While GAD antibodies can occasionally be found in cancer patients with SPS, their presence is much less specific for paraneoplastic cause compared to amphiphysin antibodies. We also mentioned glycine receptor antibodies earlier, which can also be seen particularly in patients with features overlapping with PER, figure 94-5.
So amphiphysin antibodies are the key ones to look for if you suspect paraneoplastic stiff person syndrome. How is it treated?
Treatment involves several approaches. First, managing the underlying tumor if one is found is crucial. Second, symptomatic relief is very important, using medications that enhance GABAergic inhibition to counteract the hyperexcitability. Benzodiazepines like diazepam are often very effective. Baclofen is another option. Third, immunotherapy is often used. Glucocorticoids can be helpful. Treatments like IV or plasma exchange may provide transient benefit by removing antibodies. For patients who don't respond well, rituximab, which targets D cells, can be effective.
Okay. Let's move to problems primarily affecting sensory neurons. Paraneoplastic sensory neuronopathy, PSN, also called dorsal root ganglionopathy.
Right. This syndrome specifically targets the dorsal root ganglia, DRG, which are clusters of nerve cell bodies located just outside the spinal cord that contain the cell bodies of our primary sensory neurons. Damage here disrupts sensory input from the body to the CNS.
What are the symptoms?
It typically leads to sensory loss, which can be symmetric or quite characteristically asymmetric, affecting different parts of the body unevenly. This sensory loss is often accompanied by significant positive sensory phenomena, like painful dysesthesias, burning, tingling, pins and needles, or lancinating, shooting pains, sometimes at a radicular nerve root distribution. Deep tendon reflexes are typically reduced or absent early on because of the sensory limb of the reflex arc is damaged. Any sensory modality, touch, pain, temperature, vibration, position sense, and any part of the body can potentially be affected, including the face, and even special senses like taste and hearing in some cases.
What do the electrophysiologic tests, the nerve conduction studies, show?
Nerve conduction studies, NCS, show a very characteristic pattern that points towards the DRG as the site of the problem. Specifically, you find significantly reduced or entirely absent sensory nerve action potentials, SNAPs, indicating dysfunction of the sensory axons. In contrast, motor conduction studies are usually normal or only minimally affected, especially early on, because the motor neuron cell bodies are located inside the spinal cord and are spared. This dissociation between abnormal sensory and normal motor findings is key.
And pathologically, what's happening to the DRGs?
Pathologically, if examined, there is evidence of inflammation and immune attack, specifically targeting the dorsal root ganglia. This leads to degeneration and loss of the sensory neuron cell bodies within the ganglia. Consequently, you get secondary degeneration of their axons traveling up the sensory tracts in the spinal cord, particularly the posterior columns. Inflammatory changes can sometimes involve the nerve roots and peripheral sensory nerves as well.
And the associated antibodies in tumors for PSN.
This syndrome often occurs as part of a more widespread paraneoplastic encephalomyelitis picture, or alongside autonomic dysfunction. It has a very strong association with Hu antibodies, NNA1, and is considered one of the classic manifestations of paraneoplastic syndrome linked to SCLC. While other antibodies like CRMP5 can sometimes be implicated, Hu is the major player here.
Given the strong Hu antibody link and the fact that it's targeting neurons, an intracellular antigen process, what's the expected treatment response?
As with the other syndromes strongly linked to Hu and other intracellular antibodies, the prognosis for significant neurologic recovery from PSN is generally poor. The damage is thought to be primarily T-cell mediated destruction of the sensory neurons, which is very difficult to reverse. Treatment focuses mainly on finding and controlling the underlying SCLC. Glucocorticoids might sometimes help stabilize symptoms or reduce pain, but the benefit of antibody-removing therapies like IVIG and plasma exchange is considered unproven or minimal for this specific condition. Reversing the established sensory neuron loss is unfortunately very difficult.
Okay, let's broaden out again and talk about paraneoplastic peripheral neuropathies more generally. What forms can these take?
Peripheral nerve disorders, neuropathies, can certainly occur in cancer patients at various stages and through different mechanisms. Those that appear later in the course of advanced cancer, or perhaps in patients with lymphoma, often cause mild to moderate sensory motor symptoms. Weakness and numbness, usually worse in the feet and hands. These are frequently related to axonal degeneration, but the exact cause can be complex and multifactorial, may be nutritional deficiencies, metabolic issues, or even effects masked by chemotherapy. It's not always clearly paraneoplastic.
What about neuropathies that present earlier, maybe even before the cancer diagnosis?
Neuropathies presenting earlier in the cancer journey, or is the first sign, can sometimes be more aggressive. They might show rapid progression over weeks or months, and occasionally even have a relapsing remitting course. Pathologically, these often show more definite evidence of inflammation on nerve biopsy, sometimes with significant axonal loss, but sometimes with features of demyelination, damage to the myelin sheath around the nerves.
Does the type of damage matter for treatment?
Yes. If demyelination is a prominent feature, suggesting an inflammatory process similar to GBS, Guillain-Barré syndrome, or CIDP, chronic inflammatory demyelinating polyneuropathy, then immunotherapies like IV plasma exchange or glucocorticoids may be beneficial, just as they are in non-paraneoplastic inflammatory neuropathies.
Are specific antineuronal antibodies helpful in diagnosing these paraneoplastic peripheral neuropathies?
Generally less so than in the CNS syndromes we discussed. Specific antineuronal antibodies are less frequently detected and often less diagnostically definitive in peripheral neuropathies. The source notes that CRMP5 antibodies are sometimes seen in association with paraneoplastic neuropathies. And, as we just covered, finding Hu antibodies in a patient presenting with neuropathy strongly suggests there's likely a concurrent paraneoplastic sensory neuronopathy, dorsal root ganglionitis component.
The source mentions GBS and brachial plexitis occurring with Hodgkin's lymphoma, but clarifies the link.
Yes, that's an important clarification it makes. It states that while GBS, an acute inflammatory demyelinating neuropathy, and brachial plexitis, inflammation of the nerve network supplying the arm, are observed in association with Hodgkin's lymphoma more often than expected by chance, there is currently no clear evidence of a paraneoplastic association. This means we don't have proof that the lymphoma is directly causing the neuropathy via an immune mechanism in these cases. It might be an indirect association or coincidence. It highlights that association doesn't automatically equal paraneoplastic causation.
Good distinction. What about neuropathies specifically linked to monoclonal gammopathies? You mentioned myeloma and MGUS earlier.
Right, these form a distinct and important category of neuropathy in the context of hematologic malignancies or related conditions. Neuropathies associated with monoclonal gammopathies, where there's an abnormal M protein in the blood or urine, can arise through various mechanisms. It could be due to direct compression of nerves by tumor deposits, like in myeloma, deposition of the abnormal protein in nerve tissue, like in amyloidosis related to light chains, or potentially through the monoclonal antibody itself interacting harmfully with nerve components, especially common with IgM monoclonal antibodies, some of which target nerve antigens like AM.
So the M protein itself can be the problem?
Yes, or the underlying condition producing it. These neuropathies are particularly common with IgM gammopathies, but can occur with IgG and IgA as well. The management really depends on identifying the specific mechanism and treating the underlying plasma cell disorder, myeloma, Waldenstrom's, or managing the MGUS appropriately.
Is vasculitis affecting the nerves or muscles ever paraneoplastic?
Yes, vasculitis, inflammation of blood vessels affecting the tiny blood vessels that supply the nerves, the vasa nervum or muscles, can occur as a paraneoplastic phenomenon. It typically presents as a painful sensorimotor neuropathy, often patchy or asymmetric, mononeuritis multiplex, sometimes accompanied by proximal muscle weakness, if muscle is involved. It tends to occur more often in elderly men and may be associated with systemic signs of inflammation, like elevated ESR or CRP.
What tumors are linked?
Linked tumors include SCLC and lymphoma. The good news is that this type of vasculitic neuropathy is often responsive to immunosuppressive therapy, typically glucocorticoids, sometimes combined with agents like cyclophosphamide.
Let's circle back now to peripheral nerve hyperexcitability, also known as neuromyotonia or Isaac's syndrome. We mentioned it with Caspr-2 antibodies.
Right. As a syndrome itself, neuromyotonia is characterized by spontaneous, continuous firing of peripheral nerve fibers. This leads to symptoms like muscle cramps, visible muscle twitching or rippling, fasciculations and myokymia, muscle stiffness, and sometimes delayed muscle relaxation after contraction. Pseudomyotonia. Patients might also complain of excessive sweating.
And the EMG findings.
EMG is key for diagnosis. It shows characteristic spontaneous high-frequency discharges of motor units, often appearing as doublets, triplets, or longer bursts, even when the muscle is at rest.
And the associations. Antibodies. Cancer.
As we discussed, some patients with neuromyotonia, particularly those who also have CNS symptoms like confusion or insomnia, i.e. Morvan syndrome, have Caspr-2 antibodies. However, most cases of isolated neuromyotonia without CNS features are actually antibody negative. It can occur as an idiopathic autoimmune condition without cancer, but when it is paraneoplastic, it's most commonly associated with thymoma, both benign and malignant types, and sometimes SCLC.
How is neuromyotonia treated?
Treatment often involves medications that help stabilize nerve membranes and reduce hyperexcitability, such as anticonvulsants like phenytoin or carbamazepine. For autoimmune cases, immunotherapy like plasma exchange or IVI can be beneficial. particularly in antibody-positive cases, or those with Morvan syndrome. And of course, treating any underlying tumor is essential.
Finally, in the realm of peripheral nervous system PNDs, what about pure paraneoplastic autonomic neuropathy?
While autonomic dysfunction, affecting involuntary functions like blood pressure, heart rate, digestion, sweating, bladder control, is often a component of broader PNDs like LEMS or widespread encephalomyelitis, especially Hughes-associated, it can, though rarely, be the predominant or even the sole manifestation of a paraneoplastic syndrome.
What kind of symptoms would that involve?
This pure form affects the involuntary nervous system controls. Symptoms can be widespread and severe, including things like profound orthostatic hypotension, dramatic drop in blood pressure upon standing, gastrointestinal dysmotility leading to constipation or pseudoobstruction, cardiac arrhythmias, abnormal pupillary responses, dry mouth and eyes, Zika symptoms, anhidrosis, lack of sweating or sometimes excessive sweating, erectile dysfunction in men, and bladder or bowel sphincter problems.
Can these autonomic problems be life-threatening?
Yes, absolutely. Severe autonomic dysfunction, particularly affecting cardiovascular stability, blood pressure, heart rate, or causing severe gastrointestinal paralysis, can definitely be life-threatening.
What tumors are linked to this pure autonomic failure picture?
This rarer, pure autonomic presentation has been associated with various tumors, including SCLC, pancreatic cancer, testicular cancer, carcinoid tumors, and lymphoma. If a patient presents with acute or subacute severe isolated autonomic failure, searching for HU or CRMP5 antibodies is important, as it could potentially be the first sign of a more widespread paraneoplastic process that might declare itself later. The source also helpfully distinguishes this from autoimmune autonomic ganglionopathy, AG, which is caused by antibodies to the ganglionic acetylcholine receptor, GACHR, and is a related condition but is often non-cancer related.
Okay. Now, the chapter explicitly lists LMS and myasthenia gravis and also polymyositis dermatomyositis as PNDs in Table 94-1, but it refers readers elsewhere for detailed discussion. Based only on what is mentioned in Chapter 94 that we're focusing on, what are the absolute key takeaways about their PND status?
Right. They're included in the overall list of PNDs, Table 94-1. The key points mentioned within this chapter are essentially their classification as PNDs and highlighting their strong tumor associations and antibody links, placing them in context. Lambert-Eaton myasthenic syndrome, LEMS, is noted as a classic PND, strongly linked to SCLC and mediated by anti-VGCC, voltage-gated calcium channel antibodies, which are listed in Table 93, the cell surface group. Myasthenia gravis, MG, is listed as a non-classic PND with its very strong link to thymoma and mediation by anti-ACHR, acetylcholine receptor antibodies, also fitting the cell surface category, though not explicitly in Table 94-3.
And polymyositis dermatomyositis.
Polymyositis and dermatomyositis, inflammatory muscle diseases, are listed as non-classic PNDs, Table 94-1. The crucial point made in the diagnostic section of this chapter is that dermatomyositis is a much higher and more significant cancer association than polymyositis. This is important clinically because it means the threshold for initiating a thorough cancer screening should be much higher for a new diagnosis of dermatomyositis compared to polymyositis.
Got it. And lastly, under muscle disorders, immune-mediated necrotizing myopathy, IMNM.
Yes, IMNM is another form of inflammatory muscle disease, distinct from polymyositis or dermatomyositis. It's characterized by a typically rapid onset of severe, often proximal muscle weakness, frequently accompanied by muscle pain, myalgias, and very high levels of muscle enzymes like creatine kinase, CK, in the blood. The key diagnostic feature is the muscle biopsy, which shows extensive muscle fiber necrosis, death, but with relatively minimal inflammation compared to PMDM.
Is IMNM paraneoplastic?
It can be. It can occur as a non-paraneoplastic autoimmune condition, sometimes famously linked to statin use mediated by HMG-CR antibodies, but it can also be associated with underlying cancer. The source notes that when it's cancer-associated, it can be linked to various cancer types, without one specific type being predominant. Interestingly, it suggests that cases associated with HMG-CR antibodies, or those that are antibody-negative, seronegative IMNM, seem more likely to be linked with cancer than cases associated with antibodies to the signal recognition particle, SRP antibodies.
How does it respond to treatment?
The source indicates that paraneoplastic IMNM is generally responsive to aggressive immunotherapy, combined with effective treatment of the underlying tumor if one is identified.
Okay, we've covered disorders of the brain, spinal cord, peripheral nerves, neuromuscular junction, and muscles. Are there also specific paraneoplastic syndromes affecting vision?
Yes, absolutely. Paraneoplastic visual syndromes can occur, primarily affecting the retina, the light-sensing tissue at the back of the eye, although sometimes the uvea, the middle layer of the eye, or the optic nerves can be involved as part of a broader process.
What are the main types affecting the retina?
The two most well-known and distinct syndromes are cancer-associated retinopathy, CAR, and melanoma-associated retinopathy, MAR.
What's the difference? Let's start with CAR.
CAR typically affects both cone and rod photoreceptor cells in the retina. It's most commonly linked to SCLC, but can be seen with other cancers too. Patients usually experience symptoms like photophobia, increased sensitivity to light, progressive loss of vision and color vision, development of scotomas, blind spots in the visual field, and nyctalopia, difficulty seeing in dim light or at night. The electroretinogram, ERG, a test measuring the electrical response of the retina to light, shows characteristic abnormalities reflecting the photoreceptor dysfunction.
And MAR, linked to melanoma, presumably.
Exactly. MR occurs specifically in patients who have metastatic cutaneous melanoma. It typically presents differently from CAR, often with an acute onset of nyctalopia, night blindness, and prominent positive visual phenomena like shimmering, flickering, or pulsing lights, photopsias. This can then progress to vision loss. The ERG in AR also shows characteristic changes, particularly reduced B waves, which reflect dysfunction of retinal bipolar cells, distinguishing it from the photoreceptor loss in CAR.
What's the underlying mechanism thought to be for CAR and MAR?
It's believed to be immune-mediated, involving antibodies produced in response to the cancer that cross-react with specific proteins found within the retinal cells, photoreceptors in CAR, bipolar cells in MAR, leading to their dysfunction and eventual degeneration. Specific antibodies like anti-recoverin for CIR and anti-bipolar cell antibodies for MAR have been identified.
And the treatment response for these paraneoplastic visual syndromes, can vision be saved?
Unfortunately, similar to many other PNDs targeting neurons, paraneoplastic retinopathies rarely show substantial improvement with treatment. While stabilization of vision or perhaps partial response has been reported in some individual cases with immunotherapy, reversing the established photoreceptor or retinal cell damage is generally very difficult. Immunotherapies that have been tried include glucocorticoids, plasma exchange, IVI, rituximab, or sometimes alemtuzumab, alongside treating the underlying cancer, but significant visual recovery is uncommon.
Wow. We have truly unpacked Chapter 94 in incredible detail now. From the fundamental definition and the indirect immune mechanisms, through that critical distinction between intracellular T-cell-mediated damage and cell surface antibody-mediated dysfunction, right down to the specific clinical features, antibody associations, tumor links, diagnostic clues like MRI patterns or CSF findings, and the vastly different treatment responses for this whole constellation of specific syndromes affecting every part of the nervous system. That level of detail really feels like getting right into the mind of an expert in this field.
That's absolutely the goal, to move beyond just a surface-level list of syndromes and really grasp the underlying principles, the pathobiology, and the crucial associations that govern these complex and often challenging disorders. Recognizing that fundamental dichotomy between the intracellular and the cell surface antibody disorders and how that directly dictates prognosis and therapy is perhaps the single most important conceptual takeaway from this chapter.
Absolutely. Understanding why some of these conditions are so devastating and notoriously resistant to treatment, while others offer genuine hope for significant recovery with immunotherapy, is just crucial for anyone dealing with these patients. And that recurring theme, knowing that the nervous system can often be the first place a hidden cancer actually reveals itself, that's such invaluable clinical knowledge.
It really is. It fundamentally changes how you approach certain neurologic presentations. It means maintaining a high index of suspicion, considering the possibility of a PND or autoimmune encephalitis in any patient presenting with unexplained, often subacute or rapidly progressive neurologic symptoms, and then understanding how to systematically investigate for both the immune cause and a potential underlying tumor trigger.
And becoming familiar with those specific, sometimes unique symptom patterns like the faciobrachial dystonic seizures in LGI1, the bizarre sleep disorder in IGLON5, the dramatic psychiatric and movement picture in NMDR encephalitis, or the prominent GI symptoms hinting at DPPX antibodies, that allows for a much more focused and efficient diagnostic approach, doesn't it? It's about connecting those specific clinical dots to the likely immunological mechanism and the potential oncological associations.
Exactly. It's precisely this synthesis of clinical neurology, immunology, and oncology that defines real expertise or mastery of this topic. You're effectively using the neurologic syndrome itself as a guidepost to direct your search for the specific immune culprit, the antibody or cell type, and, critically, for the underlying tumor that may be driving the whole process.
Well, this has been an incredibly informative, really deep dive into a challenging but absolutely vital area of neuroscience and oncology. It serves as such a stark reminder of the intricate and sometimes really surprising ways that cancer and the immune system can interact to profoundly affect distant poles of the body, particularly the delicate tissues of the nervous system.
It truly highlights the body's immense complexity and how systems that evolved for our protection, like the immune system, can, under certain circumstances of misdirection, become sources of significant pathology themselves.
Understanding these paraneoplastic and autoimmune neurologic syndromes, armed with the kind of detailed knowledge laid out in your source material and that we've discussed today, really provides a powerful lens. It helps you approach puzzling neurologic presentations with a broader perspective, empowering you to consider less obvious possibilities, potentially uncover hidden diseases earlier, and ultimately make a real difference in guiding appropriate diagnosis and effective therapy in these often very complex cases.
It absolutely opens up diagnostic avenues and therapeutic possibilities that might otherwise be missed if you weren't thinking along these lines.
Definitely. And as we wrap up this thorough exploration of Chapter 94, let's leave you, our listeners, with maybe this provocative thought to consider further. We've spent a lot of time discussing how many of these immune responses are directed against specific neuronal proteins that happen to be aberrantly expressed by various tumors. Could a deeper understanding of why and how these tumors come to express these normally neuron-restricted proteins in the first place, or perhaps a more nuanced grasp of the specific immune pathways that get triggered by this aberrant expression, pave the way for novel therapeutic strategies in the future? Strategies aimed not just at treating these often rare neurologic syndromes, but perhaps offering entirely new ways to target, detect, or even control the underlying cancers themselves by exploiting these unique immunological interactions.
That's a great point. It really is a bidirectional area of research, with potential implications flowing both ways, from understanding the autoimmune response back to the tumor biology, and potentially vice versa, using the body's reaction to potentially understand and fight the cancer itself.
Definitely food for thought right there on the cutting edge where neurology, immunology, and oncology meet. Thank you so much for joining us for this incredibly detailed deep dive.